Yeah, thank you, Dr. Shruti, for kindly inviting me in this course, and thank you, AIOS. So I'll be speaking on disc imaging in neuro-ophthalmic diseases. So if you see the OCT, there is a lot of revolution in the OCT technology. We have evolved from being a time domain to a spectral domain now, which is a much greater resolution as compared to a time domain OCT. So OCT applications in neuro-ophthalmology are basically in imaging of RNFL, the GCC, and also we have applications of multicolor in neuro-ophthalmology and OCT angiography. So RNFL is unmyelinated axons of forming the optic nerve. It is a window to brain disease. Axonal loss is a promising biomarker of multiple sclerosis, and OCT is the most sensitive technique to evaluate RNFL changes. So if you see the cross section, this is how the layers stack up in our OCT. This is the ganglion cell layer, and this is the retinal fiber layer here. So this is a 30-year-old woman with an optic neuritis incident. So if you see the spectralis and the serous, both shows a bilateral RNFL thinning, damage predominance in the temporal quadrant. So here we see the efficacy of imaging. The patient has RNFL thinning even when the patient has a visual acuity of 20/20 and a half visual field, which is normal. Coming to the GCL and the IPL complex, GCC thinning is the early biomarker for neurodegeneration. It is an earlier biomarker for neurodegeneration as compared to RNFL. GCL correlates better with visual dysfunction, disability, and MRI than RNFL thickness. So GCL plus IPL is a higher correlation with perimetry. It's predictive of progression and predicts visual recovery post-surgery. So this is a 22-year-old man who has a sudden painful loss of vision, presented to us in 2013 post-IVMP and oral steroids. The visual acuity in the right eye was 6/6 in the right eye, in the left eye is 1/60. And visual acuity is 6/6 in the right eye. The old document showed visual acuity of 1/60 in the left eye. When he presented, the visual acuity was 6/9. The color vision was 16/16, and OS was diminished with 14/16. MRI shows brain periventricular flux. And if you see the serial RNFL and the GCC analysis, we can see that OCT can detect subclinical axonal loss in eyes with normal visual fields and normal visual acuity, as is seen in the progression of these charts. Microcystic macular edema is another interesting finding in cases of multiple sclerosis. Microcystic macular edema is notably seen in the inner nuclear layers, usually in the parafoveal foveus pairing. When optic neuritis due to any reason, including MS, this is because the retrograde degeneration of the inner nuclear layers also can be seen in intermediate uveitis and Finglomyard side effect. Now, this is a case of papillary edema where the finding is acutely thickened retinal nerve fiber layers, whereas in chronic cases you'll have RNFL thinning in optic atrophy. GCL plus IPL analysis can give you early detection of the neuronal loss, and GCL is a good prognostic indicator. Now, this is a 37-year-old female who used sudden dimness of vision for 1 month, severe headache, vomiting, binocular double vision, diagnosed elsewhere with cerebral venous thrombosis, MRV, no flow in left transverse sinus, treatment with cerebral anti-edema and drugs and warfarin. As you can see, there is a progression of the, am I audible? Yeah, this is a patient. This is the patient who's at present in the picture is like this: 6/9 in the right eye, 6/36 in the left eye, and final follow-up is 6/6 and 6/12. And you can see the progression of the GCL and the IPL thickening, as can be seen in the charts. So multicolor confocal imaging is another interesting imaging modality for neuro-ophthalmic disorders. It generally gives you information about 3 layers. three wavelengths. That is the infrared. This is the infrared channel. This is the green channel, and this is the blue channel. And this is the composite multicolor image. Now it is very useful in differentiating true disc edema from false disc edema. So this is a case of optic nerve head drusen, where you see there is a greenish discoloration around the disc, but the margins are absolutely fine and well demarcated. There is no spillover of this green lesion into the adjacent orangish retina. On the other hand, if you can see, this is a case of a disc edema. So you can see there is true disc edema, where you see the contour of the greenish elevation is irregular, and there is extension of this greenish margin into the adjacent retina. So, greenish discoloration of MC images has been observed due to result from any type of thickening or elevation. But if it's a true pseudo disc edema like an optic nerve head drusen, the thickening will be more regular and well defined without any ragged margins. On the other hand, if it's a true disc edema, you will see it as a ragged margin. This is again comparing our true disc edema with optic nerve head drusen. You see this is not extending beyond the optic nerve head margins. Also, it has some role. There is an entity known as occult disc pit, where you can see this is a clinical color fundus photograph where you are not able to see the disc pit, but you see macular edema in the macular region. When you do multicolor imaging, you are able to see the optic disc pit here, which is not seen in the conventional color fundus photograph. So this is one other application of the multicolor imaging. OCT angiography evaluates microvascular abnormalities, vascularity of the radial peripapillary network, metabolic activity, number and vitality of the nerve fibers present, measures peripapillary capillary density and flow index. OCT evaluates flows in a precise and longitudinal manner. So this is a patient of disc edema, where you can see there is a flow void here around the optic disc region. So this is a case of NAION. This kind of flow voids in the peripapillary region is common in cases of NAION. So to conclude, measure and detect RNFL GCL loss in optic neuritis. It helps in prognosticate vision and field changes pre-op in papilledema and optic neuritis. Multicolor imaging to differentiate between true and pseudo disc edema, and OCTA is emerging as a new tool. I acknowledge Dr. Sujata Guha for help in this presentation. Thank you very much.